G'day, folks. Mick and Alex here. Just the first of many podcasts, we hope, in relation to VTR's work, in particular about our use of guidelines and protocols, but also helping us to understand the origin of those guidelines, I suppose, and the illnesses and injuries that are behind them. So, as you know, we've got new guidelines that have been sent out recently, version 1.7, which were approved by the department just prior to Christmas. They've been sent out to you now, so it'd be great if everyone familiarised themselves with them so that they can practice accordingly. And we'll work through some of the changes today, as I say, in the first of many podcasts. And then what we'll do over time is we'll come back to you with discussion around specific guidelines, specific conditions that VTR see. It won't always be Alex and I, it might be Alex and someone else, or me and someone else. And we'll cover off the major issues of concern for us in thoroughbred racing in Victoria. So we've had a little bit of feedback, thanks to Adam in particular, who sent us back some sensible feedback on the new guidelines, and we'll work at them over time. We've made some changes, but we know we've got other changes to make in time, but we think we've got a pretty good base to work from now. So,
yeah, great. I think the video's a bit fussy, but maybe most people will just listen to this. Hopefully the audio comes through good. But yeah, like Mick was saying, there's new guidelines out, but that's 100+ pages, so it'd be good to have another way of consuming them. Some people can listen better than they prefer to read and so forth. And yeah, exciting. We can see if we could provide some sort of, short snippets for what to do in certain situations and regular updates every now and then. So this will be fun, Mick. I'm excited about it.
Glad you are. Righto, here we go. So,
let's go.
Of note in these guidelines, if you look at the preface, it's got a couple of pretty important pieces of commentary in there. One is that all of the guidelines are now combined. So the first responders, the paramedics and the doctors' guidelines are all in the same document. So for the purpose of us being able to see what each of us is expected of each of the various groups, and so that the pattern of care flows from first responders through to doctors' intervention. It should be noted that as is in line with normal non-emerge guidelines, for first responders, this document are protocols, so they are to be followed. So the sense is that they're followed absolutely. For the senior paramedics and the doctors, they are guidelines, so they will need to be varied from time to time. They may need to be added to, and they may need to be varied right from the start. Almost always they're going to work. We understand that because that's ambulance experience or first pre-hospital experience, is that they almost always work, but they won't apply to every situation, so they need to be modified. In some senses, though, they're not to be modified, I guess. If you meet the state trauma criteria for a significant injury or a major trauma, physiologically or by pattern or whatever it is, you don't vary that guideline, you follow it. If you meet the nexus criteria to have your vertebral column immobilised, or then you need to follow it. They're not guidelines. They're there for a very specific reason. They've been well researched. They're very well understood to save lives or to improve morbidity and mortality. So in some senses, there are guidelines that categorically need to be followed as they are. And the guidelines they're contemporary. They're in line with conventional medicine and conventional pre-hospital practice. So we should have very little trouble following them for the largest part. What should be noted also is that the role of the team is defined very clearly. And so the leadership of certain cases is also defined. So it talks about where doctors lead and where senior paramedics lead. And so what we've done in essence is assign the leadership role to certain cases based on who would normally do those cases or who would normally lead those cases in their normal environment. So clearing jockeys to ride, signing jockeys off so that they can't ride, doing consultations of general practice sort and so on. Obviously, the doctors are going to do that. In terms of the multidisciplinary team, and then we had a serious fall or a serious trauma, paramedics would normally lead that in the pre-hospital environment. The expectation is they do so here. So the paramedic takes the lead. They work as a team. They discuss their plan of care with the team, and everyone contributes, but the paramedic takes the lead role. And the expectation is, as we've discussed at training previously, the paramedic will do the assessment, take the history, do the assessment. We'll set the plan of care. If the airway needs to be managed during that time, bag valve mask ventilation or whatever it might be, then the doctor will take responsibility for that. The first responders will help set up monitoring, do splinting, and then get a bed and board and so on and help us to get the patient out of there. What we do need to do is to develop a very clear sense of what a trauma response looks like and how you work as a team. And I know the paramedics are very familiar with that because they do it every day, but we need to make sure that we have very clear systems in place so that no matter who you're working with on any given day, we all understand our roles clearly and we'll repeat those roles no matter which track we're at and which team we're with. So that's clearly defined in the guidelines. So hopefully that gives us some direction for the future, and we'll certainly cover that off in our training. Alex, comment?
Oh, beautiful. That's a lot of points you hit on there. Just to reiterate and comment, so you mentioned that now in the new guidelines, everyone's treatment's on the same page. I think that's one of the key principles to a good teamwork is that everyone knows what's going to happen. So deliberately putting sort of all the interventions on the same page and just having tick boxes who can do what, perfect. And that leads into all the discussion you had around teamwork and wholeheartedly agree the ICP, the paramedic leads the job, and for many reasons, but one of them being that they've done it hundreds of times more than most doctors who do this sort of job because it's early after trauma. That's the realm of the ICPs.
Yeah, and I think it's also, we mentioned in the guidelines that everyone is there to lead, so everyone's there to take a role in patient care, and you need to speak up if you think things need to be done differently or if you see something that needs to be noticed by others. That's well understood in pre-hospital care now. Certainly the paramedics are taught it. I know all the doctors that work in hospital systems will be taught it. And the expectation is that you do function as a team and you act as a patient advocate. That's all of us. So, if you're a first responder and you're working with an intensive care paramedic and a doctor, doesn't matter how senior they are, if you think something needs to be done differently, then speak up on the patient's behalf. It is well known in clinical care now that if you do that, you get much better results. It is much safer for the patient. And teamwork has been well researched in medicine, and what's seen as a pit crew approach to care in the likes of stroke and AMI and so on. When people work seamlessly because they're practiced and they understand each other's role, it improves outcomes without changing any of the medicine.
Yeah.
So it's fundamentally important that we do that and do that, as I say, consistently on every track around Victoria, no matter who you're working with.
Yeah, and that's why it's so important to have clear guidelines and have people be familiar with them because, any given shift you might work with a bunch of new people that you've not worked with before or in a long time, but whatever the job is, everyone sort of knows which page of the guideline we're going to open and what the different roles are in there. You mentioned also before the sort of guideline and versus protocols, and that these things are protocols for FR3s, but guidelines for doctors and paramedics. But I think within the sort of guideline there are some that are protocols and some that are open for interpretation. And like you have done a lot of work around the sort of state trauma system, and if the heart rate's above X, let's treat it as a major trauma.
Yeah.
That's not to say that everyone with a heart rate above that cutoff is going to do poorly and from the trauma point of view, nor is it to say that everyone with a heart rate less than that is in the clear.
That's right.
But a line had to be drawn somewhere.
Yeah.
And
and of interest, those physiological criteria
Yeah.
that are set in the state trauma criteria or the state trauma triage,
Yeah.
they're well researched.
Yeah.
So they've been researched, validated a couple of times now, and they've been adjusted accordingly. And the expectation is, and it's very much the expectation in pre-hospital care, if you meet those guidelines, then you get triaged to the appropriate place. Now, you'll see patients settle over time or change and vary. Some of them get worse, some of them get better, but nonetheless, those guidelines are well followed now. If you think about it from an ambulance perspective, EV has a compliance rate of about 96, 97% with trauma triage to the right destination. And those that aren't triaged to the right destination who turn out to be major trauma patients are all reviewed. So the State Trauma Committee reviews it, and the CEO of the relevant institution where the decisions are made, if it's ambulance makes the wrong decision or a hospital makes a decision that's not in the patient's best interest, the CEO of those organisations gets a letter from the chair and they're expected to provide a response and a review. So they are taken very seriously. So in that case, they're not a guideline. They're very clearly a protocol, and you'll make clinical decisions around it, I'm sure of that. But by and large, most patients who fit into the criteria need to be triaged accordingly. So either to a major trauma service if we reach within 60 minutes, to a trauma service, not a major trauma service. If it can't, get to the closest regional trauma service and so on. And for us, really, it's just guidance because we don't make the triage decision. But if you make a decision and you make the right decision, and when you hand over, you let people know that they meet the criteria on these grounds, then hopefully the AV staff will respond accordingly. They are very familiar with triaging along those guidelines. They've been in place for a long time now, since 2000, in fact, and they've saved a lot of lives. So in that sense, just as you give an aspirin when someone's got ischemic chest pain, you apply the state trauma guide, the state trauma triage to major trauma. It saves lives just like medicine does.
And if they're a bit tacky and that's because of dehydration or stress or pain or whatever, that might be the case, but that doesn't mean that you shouldn't sort of treat the elevated heart rate as, ticking one of the boxes in the trauma criteria. So we don't want to
and of course,
away abnormalities.
Yeah, absolutely. Yeah, so you got to be careful about explaining away abnormality in medicine, as you know. So, as you know, the old axiom is think the worst and hope for the best. Now, if someone's just tachycardic and they don't have serious injuries and they don't have other signs, well, then you're going to sit and wait and they'll get better, but that'll declare itself. And of course, you'll have, if they have got injuries and they're tachycardic, then you need to respond. Plus, the injuries themselves might be enough to be the indication. They might meet the pattern of injury or the mechanism of injury criteria, as well as some physiological criteria. But they are very much a protocol, and they've seen that way in medicine. So the Alfred and the Melbourne respond the same way, and the Trauma Victoria, which runs out of ARV, the Trauma Victoria guidelines are consistent with that. So, and it provides guidance for practitioners outside of the major trauma services for triage, and the triage criteria are identical.
Yeah. Beautiful.
So we've got a few changes to discuss. Essentially, so a lot of the guidelines have been renamed. They're renumbered. There were repeats of guidelines, so they've been amalgamated. And for example, all of the issues that fall under major trauma are covered in one trauma guideline, and then there's a specific guideline, say, for spinal cord injury, chest injury, and so on, compound fractures, etc. I'll just discuss quickly. I'll mention a few of the things that have been added, particularly medications and other changes. But we've added aramine, so we'll put aramine on the trucks soon. But aramine's basically, if you look at the trauma guidelines, aramine's been included for hypotension. As a last resort for hypertension, as it's used in
also known as metaraminol.
Correct.
And
in the guidelines, of course, there's a pharmacology sheet for these drugs as well, so worth having a look at for those of us that are using it. But of course, the paramedics are very familiar with it, given that they use it already. And it's made a bit of a resurgence, Alex, you'd say, in trauma medicine over recent years. We stayed away from inotropy for a long time. But it's been added back in as a last ditch. You don't get adequate resuscitation via volume, or indeed you're so severely shocked that you're about to lose your life and you need to be resuscitated quickly.
Yeah, and I think the other reason where this come in handy in our case, some of these might have spinal shock, wouldn't they?
Yeah. And it's in the spinal
permanent, or a better peripheral squeeze wouldn't hurt.
No, exactly. So it's been added to the spinal cord injury guideline as well for persistent hypotension. So importance, I think, is that we've added ketamine and fentanyl to the guidelines. And so for the management of pain and also for the management of procedural pain, so where you might have to straighten a leg or relocate a shoulder, then there's the opportunity there to use methoxyflurane and ketamine together to before you undertake the procedure. What will happen with ketamine and fentanyl? If we get a health service license, the VTR will carry those drugs and we'll pick them up and bring them to the track and so on. If not, then we'll provide a mechanism for the doctors to get it and reimburse them. But hopefully we'll have a health services license soon to carry these drugs, and then we'll be able to get on with it. But again, the sheets are there. We'll do some education around ketamine for the doctors, for those that are unfamiliar with it. Everyone's familiar with opioid analgesia, of course, but ketamine will be unfamiliar to some. But it's a fantastic drug for analgesia in trauma.
Yeah.
And so at low dose, a very good analgesic. At higher dose, a very good anaesthetic. And it'll be a great boon to us. It is part of conventional trauma management, and so it's well overdue that we'll have it in our guidelines.
Yeah. I don't think there's anything ketamine doesn't work for, is there?
No, it's a great drug. It's a great
You
drug.
just got to get the dose right.
Yeah. And the beauty of it is it's safe. So you're thinking, 20 milligrams will generally sort most people's pain out, particularly if they've had a little bit of narcotic.
Yeah.
You might need a little bit more. And then you think in ambulance, we use up to 400 milligrams to put people to sleep when they're severely agitated. Even 400 milligrams, they don't lose their pharyngeal and laryngeal reflexes. They keep breathing, but they're unconscious or certainly unable to respond verbally and physically, and they're well settled. It's a very stable drug to use from a cardiovascular point of view. Is known to cause a little bit of hypertension, but in the cohort we're talking about, that shouldn't be a significant issue anyway. So terrific drug, and as I say, the pharmacology sheet's there, but it'll be a great boon for us. And when we see these badly injured jockeys with fractured limbs and so on, it'll be a significant improvement. I think it's important, and when we've talked about this in our application to carry these drugs for VTR, is that the management of pain, the relief of pain, is considered a fundamental human right. And so to do it properly and to do it in line with conventional medicine, I think is very important for us.
Yeah. And to get access to it, you touched on there, we'll do work and try and get it in-house. In the meantime, if, doctors can obtain it, just write it on the doctor's prescription pad. Morphine's free because it's on the sort of doctor's bag. 5 ampules of fentanyl cost you $10, and 5 ampules of ketamine might cost you $250. If people are prepared to do that, surely there's a way get that
reimburse that. Yep. So it makes sense to do it. If you've got the capacity to do it, we should be doing it now. The guidelines are there. It's time to get on with it and to make sure these people that are getting badly injured are getting proper care.
Yeah,
might be one of us who gets injured too. So, God forbid, but nonetheless, we'd like to be treated properly.
We have it around.
There is a new pharmacology sheet for ibuprofen. There wasn't one previously, but everyone knows about the drug, so it's there.
Yeah.
Of interest, midazolam's been added under ketamine for emergence reactions. So clearly some people, when they have ketamine, respond negatively in the sense that they hallucinate, they have dysmorphic type experiences and so on. It can look pretty disconcerting when you see it, especially when people can't express themselves, but their eyes are racing around all over the place. And they're starting to contort themselves. So midazolam resolves that. You only need a little bit, 0.5 milligram to 1 milligram. It generally sorts itself out. So, but it's been added, so it's worth having a look at that guideline.
Yeah.
We've also, aramine's also in the guidelines for hypertensive tension pneumothorax, where you're trying to resuscitate someone. You need to save their life. Bit of aramine whilst you're doing the procedure if they're profoundly hypertensive.
Yeah.
Makes sense. Pornography's been added in the guidelines, in a number of guidelines. And for example, in the spinal cord injury guideline, it's there. So you can measure whether people are hypoventilating or not. And so we'll add capnographs to our monitors. So they're set up, ready to go. All we need is the little tube that connects you up and gives you samples the gas for you. We've added cefazolin for paramedics and doctors with compound fractures.
Yeah.
We know that, Alex, that early antibiotics in a pre-hospital environment prevent sepsis, save lives.
Yeah.
So when we've got dirty fractures and so on, we've got cefazolin, which would be a bit of a boon. And often we're a long way from help. So, they might not get definitive care for some hours, some of these guys, if they go to a regional trauma service and then end up being flown to Melbourne. Sometimes care gets some of these things get missed. So it makes sense that we start it as soon as possible, give people the best possible opportunity of not finding themselves really sick later on.
Yeah. No, that's it. Yeah, open fracture, the risk could be many things, but osteomyelitis and just long-term issues from sort of bone infection, that's what we got to prevent. So you got to get some antibiotics on board within 3 hours would be all the sort of international guidelines. So metro meetings, and that should easily be achieved with the help of IV, and get them as soon as they hit the door at most trauma centres, they get a shot of tetanus and cefazolin. But for those rural meetings, we might do them lots are good, particularly if that's the only injury.
Yeah,
You know, if there's a
yeah.
major trauma, lots going on, this shouldn't take any sort of clinical priority. But if they've fallen down, they're down but up. You know, they GCS 15, but they got a bone poking out. Surely within 3 hours we can get a line and some cefazolin into them. Eh?
You would think so? You would think so?
I reckon 180 minutes, even I can do it in that time. So good. All the drugs that's added, TXA, tranexamic acid.
So we had TXA in the guidelines previously,
Yeah.
obviously, and it's there for severe bleeding in trauma. We haven't used it yet, so it won't be too far away, no doubt, because when you say these things, obviously things pop up. They have to happen. Statistically, it's going to happen at some stage, but it's an easy protocol, really. So tachycardic, hypotensive, unresponsive to immediate filling, gram of TXA, and the instructions are written on the kit, which is very handy. A lot of people will be unfamiliar with it. There are other uses for TXA, of course, which we need to think about now, but it is there for severe bleeding trauma. And, as I say, some stage we're going to need it.
Yeah,
before we got it, we had some cases that needed it. And of course, hence we put it on, and now we haven't seen one since, but that's Murphy's Law.
Yeah. Now, but yeah, with TXA, it's a wonder drug, and people who do a bit of time in ED would have seen all the different uses, and there's trials backing all this up. But if we've got an epistaxis, a bit of intranasal TXA wouldn't hurt. People with hemoptysis, a bit of inhaled nebulized TXA, or even if you've got a wound that's sort of constantly using a bit of TXA on some gauze and apply that, that'll solve it 9 times out of 10. Yeah.
And I think, Alex, some of those things, I mean, we've got epistaxis guideline, and we now need to start thinking about these things that we see commonly that we can provide a solution for at the time. There's a new immunisation, CPG. That's because VTR does some immunisations. It doesn't apply to everyone, but for those who are immunisers, there's a guideline there. Victoria asked us to develop that some time ago, so that was it's been there for some time, and it just has the anaphylaxis guideline attached to it, so that if you are immunising, you've got the guideline in front of you on the day, because it is a risk and often can be a pretty serious consequence of being immunised. There's a new oxygen guideline called Oxygen Therapy, reflects current Ambulance Victoria and international practice in relation to the use of oxygen in medicine, and it's a graded approach to oxygen use. Of note, a patient who's critically injured, irrespective of the science on this, around the world, people are still given oxygen in the first instance, so it doesn't change our use of oxygen in those severely injured, but there is some guidance around patients once they're well saturated and they're stable, and also you're seeing patients in the crowd and so on as well. So we need to think carefully about how we use oxygen. The mindset's changed around it being helpful in all situations to being harmful in some. So you need not to think you're always doing the right thing by giving someone oxygen, because that's not the case.
No.
And there's a fair bit of science on that, and some science that obviously I've got a bit of an affinity with. But anyway,
this was your idea. Now, don't be humble about this. So the whole world was filling people up who had AMIs with oxygen, and Mick said, "No, surely this can't be good." And for those that know, the Avoid trial, small RCT out of Victoria. What was it?
600 odd patients. Yep.
Bang! Now the whole world has realised that oxygen is toxic. It's lethal, it takes about 80 years to kill you, oxygen. Just drip feed oxygen for 80 years, and then, now that's the chronic ambient stuff, but if you give it to AMI, it increases the size of the myocardial infarction.
Oh, about 40%, yep.
Yeah.
So it's very significant. And there are other risks, of course, as well, but, oxygen-free radicals trigger apoptosis, and so if you want to tell your cell that's been programmed to die early, that's a good way to do it. But anyway, so that's there.
Yeah.
But it's a bit of a tricky guideline, but there's a few stages to it. If you just, you go, well, I've got a SAT less than X, 85, I do this. I've got a SAT between 92 and 85, I do whatever. So just have a look and familiarise yourself with it, and then you can always commence oxygen in a seriously ill patient and then consider what you do afterwards. There's a guideline for syncope. We see a lot of syncope, not generally in the race of Victoria people necessarily, but we certainly see it in the crowds. So,
Yeah.
and of course, assessing someone for syncope is a skill, and their history alone will generally give you an idea of whether it's orthostatic, reflex, or cardiac.
Yeah.
But you do need to make that distinction. And then if you can't provide an adequate explanation for the syncope, then the reality of it is you go to hospital. And you can't assess someone with syncope without having done proper neurological assessment and an ECG. And then if you don't know how to read the ECG, then of course your obligation is to get someone to read it or send them to hospital.
No.
You've got to remember a lot of these patients that suffer syncope, and we see it many times in elderly people, they've got things like sick sinus syndrome. So by the time you see them, the immediate cause is resolved. The underlying cause is not, but the immediate problem has. So they've been bradycardic for a period, they've collapsed, they go back into their normal rhythm. You see them, you think, oh, well, they've had a reflex syncope or an orthostatic syncope. Not necessarily the case. And the other thing too is if people have they're confused afterwards, so they're like in a postictal state, they've been incontinent of urine, they're agitated, whatever it might be. That's not what you see after syncope. That's what you see after seizure.
Yeah.
So you've got to be careful not to say, oh, well, you've fainted and therefore you're okay to stay here when you've got signs of having had genuine seizure. And those things are, some of the signs. So those things are described in the guideline. And in all of the guidelines, in fact, what we've done is we've expanded the guidance notes, expanded some of the pathophysiology of the problems, and so that you've got enough, I think, to read to understand why the guideline is what it is.
Yeah.
And so hopefully that leads you into the guideline nicely.
So with the syncope, we called to the grandstand or rooms or whatever, see someone who's fainted, passed out, but they're now back to it. Really, the question is, do they need transport or not? And out of all the potential causes of syncope, if it's clear-cut, sort of vasovagal, hot room, crowded, they're hoarse, just one, they're excited, they were given some blood at the same time, this is all the stuff that makes people have a vasovagal. If it's clear-cut vasovagal, sure, they don't need to go.
Yeah.
But then there's a bucket of, could be cardiac or others. So,
You're on your 14th can at the races, you're in the sun, you're sitting in your deck chair, and then your horse wins and you jump up and you faint. Well, that might be a faint.
Yeah.
But you do need to assess someone properly irrespective. So not to assume.
Yeah.
And of course, some of these people can be quite difficult afterwards because they don't want to go anywhere because they want to get on to the next can and the next race.
Yeah.
But you can run yourself into strife because it may well be something underlying that you've missed if you haven't had a proper look.
Yeah.
So having a proper look at these people is the cornerstone of good medicine in any circumstance. So I don't think you'd ever go to anyone with syncope and not assess them based on the fact that they think they've fainted. The other thing too is if people do faint, particularly older people where their autonomic nervous system is deteriorating, they don't recover all that quickly. So remain hypotensive often for long periods of time.
Yeah.
So you've got to be patient. If they're well otherwise and they're just hypotensive and they've not got signs of other illness, it's worth just hanging for a bit, getting them better, waiting, sometimes that might be 20 minutes, half an hour before they're up and about. And then sit them up slowly, make sure they're okay, check their blood pressure lying and standing, make sure that they can hold their blood pressure in a standing position or a seated position before you give them the all clear.
Yeah. Yeah, I think it's interesting with this sort of stuff that the sort of access point into any guideline might be very benign, just a faint or the other week, we were doing a job to get a call just to give an ice pack to a hand. And I think the job is sort of to zoom 2 steps out and look at this as a whole, and that ice pack for the swollen hand that of course turned out to be a fracture. And similar with syncope, it's just a faint, can you just go and check them over? Well, hang on, 2 steps back, patient's collapsed. What's the surrounding story here? And you'll uncover.
And I think that hand example is a good example in the sense that you go, what the person wants isn't what they need.
Yes.
But nonetheless, it might help with a bit of pain, but it's not going to do anything else. But there is some general healthcare advice then about you shouldn't be walking around with untreated fractures for periods of time. So this is a 7-day-old injury, still riding, still pulling on the hand every day, so it's never going to heal itself.
No.
And then the risk of having avascular necrosis, whatever it might be, is a real risk. So those are things that, it's about stepping back and having a look, and then giving, even if it's not in our guidelines and it's not our remit, we're not there, we're there to provide immediate care, and you go, well, this is a chronic problem now, a 7-day-old problem, but certainly the advice and following up with doctors and hospital, whatever it might be, to get him seen, obviously helps and gets him on the way to proper care.
Yep.
Even though he doesn't report it till 7 days after the incident. And it's just
I'm a hand surgeon now. Yeah.
So it's tricky when people want to keep earning an income. So I get it, but nonetheless, we do see people with some pretty serious injuries that they carry for a bit.
And just as a side note to this, talking them into getting the actual tests, like that's an art. You've got years of experience with this, but convincing this guy, hey, you need to go and get assessed. This could be serious, you know. That because he would have been very happy if we gave him an ice pack and strapped him up and say, see how you go,
Mm-hmm.
So
so it is important.
About that
we should. We'll do a chat on refusal of care, or refusal of treatment, because I've got a very clear view of it. I've seen over a lot of years, very few people genuinely refuse when they're fully informed.
Yeah.
So if you're kind to them, you build a relationship, and then you provide them with the information they need to make a reasonable decision. Very few people make the wrong one. Most people, they call in the first place because they're concerned.
Yes,
so
that's right.
If you call for an ice pack, and there is a fair bit in triage, and it's well understood that if you ask people what's troubling them the most, you're more likely to get to the bottom of the problem. So people will complain of things, and you'd say, well, actually, what's troubling you the most? What's your biggest concern? And if you add that triage question to triage in the first place, you tend to get to the bottom of things much better. So, but anyway, we'll do a talk about refusal of treatment at some stage, because it's very common to see it written on our PCRs and in ambulance PCRs and so on. It's often the easy way out. But if you've done a good history and good assessment, you think someone needs to be treated, then I reckon, well, more than 99 times out of 100, probably 0.01% would say, no, I'm not going. And you do see some people make some bad decisions for themselves. They're allowed to, they're adults. But nonetheless, almost always they make the right decision.
Yeah. Now, that's beautiful. Yeah, we'll do a thing. Here's the top 10 sentences to fire back at the person who tries to refuse. And now that'll be a great talk we should do. And to your point there about, if you ask the patient, what's the most concerning thing with this hand, just using a simple injury as sort of an example there, it wasn't pain or swelling that was his. He was worried what's going on underneath. And bang, well, that's the opening of the door to say, well, you're worried, we're worried, probably it's broken, go and get a scan. Okay, and now he's on the right path. So
Agreed.
Ask them what
a couple other minor changes. Atropin's been added to the CBGs for just with hypersalivation. Some people have had ketamine will hypersalivate. It's generally not a problem. A little bit of simple suction normally sorts it out. But if they do hypersalivate, then atropin's a very good solution for it. It works really quickly, which is very nice. And the other is lignocain's been added for intraosseous insertion. So that if you're sticking an IO in, then you put a bit of lignocaine in the initial bolus, and then the infusion doesn't hurt, which it tends to. Cold fluid in an IO tends to make people very uncomfortable. That covers off the bulk of the changes, I think, Alex. And as I said, we'll come back to the guidelines specifically. But they're the things that have changed. All the guidelines have been changed. In fact, very few of them look the same. And the format has changed, and there are little boxes at the end, which is the actual clinical treatment. So have a look at them, familiarise yourself with that part which is yours in the first instance, but also read that's relevant to the other staff, and understand what they're there to do, and it also enables you to assist them once you understand what their job is. And if you think about it, and a very good example, and we've got a number of guys that work for us that worked at Air Ambulance, some of them for a very long time. Their navigator acted as their assistant. And so they weren't trained in medicine, but they were trying to assist a very experienced micro paramedic to get set up at the job, draw the drugs up, put lines together, get the right gear out, and so on. So you can do it without necessarily understanding exactly what they're up to, but you can be a very good second pair of hands if you know the paramedics guidelines and the doctor's guidelines. By all means, familiarise yourself with everyone's practice to your level of practice. These are the expectation is we now move to these. And by and large, not too much change, so it's not such a big thing to swallow, but there is a little bit there. And I think the big things will be, particularly the improvement in analgesia will make a huge difference.
Yeah. Now, mate, this is exciting. You and I could talk about this stuff all day, couldn't we? But the question is how long people could listen.
That's it, correct.
But we will keep the episodes at no more than half an hour, and there'll be some short snippets slid into where they belong. And
Yeah.
now this would be fascinating. Send us any thoughts you have, or if there's missing guidelines or things that's unclear, we need to know.
Yeah.
You know, are there issues we encounter, clinical presentations that aren't really adequately covered by the guidelines? We'll just make a new one or fit it in. So,
yeah,
we're pumped.
We've got ourselves in a position, I think, these guidelines now is to be able to review them on a methodical basis, on an annual basis or thereabouts, and also to improve things in between if we need to. So I think we're ready to go, and I think the department have approved this lot, so we'll get around to making the necessary amendments and also adding anything that we need to add relevant to the work we do at racing. Good on you, Alex. Well done.
Well, thanks for your time. See
Good on
you all.
Take care. Thanks, guys. Appreciate it.